How's it going, guys? We have a medium difficulty question for ECGs, and we've got a 54-year-old dude who's got a 2-day history, progressive shortness of breath. He's had chemo, radiotherapy for lung cancer a year ago, COPD, smoking 2-pack cigarettes daily, 40 years. He's got JVD, 2+ pedal edema, lungs are clear, auscultation, distant heart sounds, blood pressure 105 on 80, renal function tests are elevated, ECG shown. What's the most likely explanation for the findings? We'll talk about the ECG as we move through. Choice A, anterior myocardial infarct, wrong fucking answer. So this would be ST elevations in the anterior leads, V1 through V3 to 4. And even if you're not an ECG expert, you can clearly look at the leads here and see that there are not ST elevations in V1 through V3. USMLE wants you to know that this is the left anterior descending artery. Wrong fucking answer. Choice B, pericardial effusion, correct answer. So what we have here is electrical alternans with low voltage QRSs. When we say low voltage QRSs, you see how the amplitudes here are not that significant above and below the baseline, right? Don't they appear short, these very small vertical aspect of these leads? So that's what we have here, okay? It's low voltage, and it's because we got fluid over the heart, where the electrical activity that's detected by the leads is decreased, attenuated. And then there's fluctuation, electrical alternance in terms of the amplitudes because of the movement of the fluid. It's just buzzy. I gotta know this ECG shows up a couple times, the 2CK NBMEs. But for step one, obviously it's fair game. You verbally need to know that it's electrical alternans or low voltage QRSs. Now, tricky aspect of this question is that cardiac tamponade will present with, which by the way, cardiac tamponade equals pericardial effusion plus low blood pressure. Tricky aspect is that tamponade classically presents with Beck triad, number 1, JVD, which we have, number 2, muffled/distant heart sounds, which we have, number 3, hypotension, which we don't really have, okay? But the ECG is pathognomonic, okay? So this is what NBME will do sometimes, and there's an NBME question that pretty much gives you the same blood pressure. Okay, they give you a 104/80. OMG, I made it 105/80. Doesn't fucking matter. Okay, but some students will get thrown off by that. Don't. Okay, but classically it's Beck triad, as I mentioned. Plus or minus pulsus paradoxus for tamponade, which is a drop in systolic blood pressure greater than 10 millimeters of mercury with inspiration, which the question doesn't have to mention. But let's hop to the others. Choice C, inferior myocardial infarct, wrong fucking answer. This would be ST elevations in the OMG inferior leads, okay, 2-3 AVF, which we don't have here. And piece of value I can give you is they not just want the posterior descending artery, but the answer can be right coronary artery. Most people are right dominant. Right dominant just means which coronary artery, left or right, the PDA comes off of. So 85% plus people, it comes off the right coronary, right dominant. If the USMLE tells you that the patient is left dominant, the anatomic sequence they want for the blood vessels is left coronary artery goes to left circumflex artery, goes to posterior descending artery. If they ask you in the setting of an inferior infarct and left dominant circulation, wrong fucking answer. Choice D, pericardial inflammation for pericarditis, wrong fucking answer. So they would tell you central chest pain, that's worse when you lean back, better when you lean forward. And you would see diffuse ST segment elevations on ECG. Demographics, I mean, obviously history of cancer, chemoradiotherapy could do it idiopathically. Could be cocaine use, they like that a lot. 22-year-old male comes in after a night of heavy partying. They can give you autoimmune diseases, SLE, RA. Viral infection, need not be Coxsackie B, but that one's classic. Wrong fucking answer. Choice C, posterior infarct, wrong fucking answer. So very low yield, but you could just be aware in theory this would be ST depressions in the anterior leads. Okay, it's essentially ST elevations out your back, which appear as ST depressions on the anterior leads. Okay, they're just the opposite direction. Wrong fucking answer. You know the deal, and team, make more content on the subscribe channel. Appreciate your time. That's it.